Welcome to the deep dive. Today we're looking into a condition called Tolosa-Hunt Syndrome. It's quite rare, actually,
hmm
but it causes this very specific painful weakness in the eye muscles. We've got a solid overview here from UpToDate to guide us.
Exactly. And, for you listening, if you want to really get the practical points without digging through dense medical texts, this is kind of your shortcut.
Yeah, we're pulling out the key stuff you need to know about Tolosa-Hunt.
Our mission today is pretty focused, I think.
Right. When should you suspect Tolosa-Hunt? How do doctors actually figure it out, diagnostically, and what else could it be?
And what's maybe a bit unusual for Tolosa-Hunt, and importantly, when can you probably say, okay, this isn't it?
Let's dive in. So, when should this condition even be on the radar? What are the absolute key indicators?
Well, there are what we call the cardinal features. It really comes down to a classic duo.
Okay.
You've got pain behind the eye, retroorbital pain is the term, and then ophthalmoplegia.
Which is just the weakness in the eye muscles, right?
Yeah.
The one's controlled by certain cranial nerves.
Precisely. The third, fourth, and sixth cranial nerves are the ones we're talking about.
Okay, let's break that down. The pain, what's
Oh.
that like? Is it like a sharp pain or?
It's usually described as constant right behind the eyeball. And interestingly, this pain can actually pop up days, maybe even up to 30 days, before the double vision from the muscle weakness starts.
Oh, wow. So pain first is typical.
Often, yeah. Though one study found the median time was only about 2 days between the pain and the palsy kicking in. People often say it feels like a gnawing or a boring, dull ache. It's persistent.
Sounds pretty unpleasant. Definitely noticeable. And then the ophthalmoplegia, the muscle weakness, what does that cause for the patient?
The main result is diplopia, so double vision. Now, in terms of which nerves get hit most often,
Mhm.
the third nerve is the big one, involved in up to, say, 85% of cases.
85%. Wow.
Yeah. Then the sixth nerve is next, maybe around 70%. After that, you have the ophthalmic branch of the fifth nerve, that's V1, involved maybe 30% of the time, and the fourth nerve slightly less, maybe around 29%.
So it's mainly those nerves controlling eye movement and maybe some sensation around the eye from V1.
That's the core of it. These nerves control how your eyes move together, so if they're not working right, things get misaligned and you see double.
Could anything else be affected, like other parts of the face
Yeah.
or vision itself?
It's less common, but yeah. You can occasionally see involvement of the other branches of the fifth nerve, the maxillary or mandibular, causing some facial numbness. The optic nerve passes nearby, so sometimes you might see changes like swelling or paleness, but significant vision loss itself is actually pretty uncommon.
Okay.
And even rarer, you might get facial nerve involvement affecting facial expressions, but that's really unusual.
And is this something that usually affects both eyes at once?
No, typically not. Tolosa-Hunt is almost always unilateral, just one side. We're talking 95, 96% of cases.
Ah.
Bilateral symptoms affecting both sides right from the start, that's much less common, maybe only 4 or 5%.
Got it. Now, you mentioned something else potentially helpful, Horner syndrome.
Yes, that's a good point. About 20%, maybe 1 in 5 patients, might also show signs of a third-order Horner syndrome.
What does that look like?
It happens because the inflammation can sort of spill over and affect the sympathetic nerve fibers running through that area. So you get ptosis, which is a droopy eyelid, miosis, meaning the pupil on that side gets smaller, and sometimes anhidrosis, which is less sweating on that side of the face.
So painful double vision on one side, plus maybe a droopy lid and a small pupil. That seems like a pretty specific picture.
It really does start to point you in a certain direction, yeah.
Who tends to get this? Is there a particular age group?
It's actually got a really wide range. You can see it from the first decade of life all the way up to the 8th. But if you look at studies, the average age seems to land somewhere around 51 years old.
So possible at any age, but maybe peaks a bit in middle age?
It seems that way, yeah.
Okay, and one last thing about when to suspect it. Does Tolosa-Hunt cause problems elsewhere in the body, like systemic symptoms?
That's a really important distinction. Tolosa-Hunt itself is localized. It doesn't usually cause systemic issues like fever, weight loss, joint pain all over, things you might see with some of the conditions it mimics.
Right.
Now, people with Tolosa-Hunt might also happen to have other autoimmune conditions like lupus, but it's thought that's probably just a co-occurrence, not that one causes the other. The focus is really on that inflammation behind the eye.
Okay, that's clear. So suspect it with that unilateral, painful ophthalmoplegia, maybe Horner's, usually no systemic stuff. Let's move to diagnosis. If you suspect it, how do you actually confirm it or at least get closer?
Right, the diagnostic approach. Well, the first absolutely crucial step is neuroimaging. And specifically, you need an MRI with contrast.
Why is that so essential?
Because the number one job is to rule out other things that can cause painful ophthalmoplegia. And some of those things are serious, like tumors, aneurysms, vascular problems, infections. The MRI gives you that detailed look at the structures behind the eye, especially the cavernous sinus.
And what might the MRI show if it is Tolosa-Hunt? What are the typical signs?
Typically, you might see the cavernous sinus looks enlarged. There might be abnormal tissue in there. On the MRI scans, this tissue often looks sort of similar in intensity to brain gray matter on T1 images, maybe similar or a bit darker on T2 images.
Okay.
And the key thing is it usually shows strong enhancement. It lights up brightly after they inject the gadolinium contrast dye. That suggests inflammation.
Yeah.
You might also see the outer wall of the sinus bulging a bit, maybe some narrowing of the carotid artery where it passes through.
But you said typical. That implies it's not always clear-cut.
Exactly. And this is a critical point. These MRI findings, they are not specific to Tolosa-Hunt syndrome. You can see very similar-looking inflammation in lymphoma, in sarcoidosis, even in certain types of meningiomas, for example. And to make it even trickier, some of those other conditions might also show improvement on MRI after steroid treatment.
So the MRI is vital for seeing something is wrong back there, but it doesn't definitively say this is Tolosa-Hunt.
Precisely. It helps rule out obvious structural things like a big tumor or aneurysm, and it shows inflammation consistent with Tolosa-Hunt, but it doesn't confirm it on its own. And rarely, the MRA might even look normal.
Really? Normal MRI?
Yeah, it can happen. Those cases can be tougher, obviously. Diagnosis then leans more heavily on the clinical picture and how things evolve. Interestingly, some data suggests maybe those patients with normal MRIs improve faster with treatment.
And if the MRI does hint at a blood vessel issue?
Then you'd likely need more detailed vascular imaging, an MRA or a CTA, maybe even a formal angiogram, depending on what's suspected. CT scans alone are usually less sensitive than MRI for spotting the cavernous sinus changes themselves.
Okay, MRI is step one, but not the whole story. What about blood tests or a spinal tap, CSF analysis?
Yeah, those are generally recommended, especially if the MRI is normal or just shows some nonspecific inflammation. The main reason is, again, to help exclude other causes.
Makes sense.
So you'd run a panel of blood tests, CBC, electrolytes, glucose, kidney, liver function, inflammatory markers like ACE, ANA, ANCA. Maybe check for Lyme, syphilis. Usually in Tolosa-Hunt, these are all normal.
Usually normal. But if they're not normal?
Well, if you see, say, a significantly elevated ESR or CRP or maybe a positive ANA, it might nudge you to think more about an underlying systemic inflammatory condition or connective tissue disease. But generally, normal labs are expected.
And the CSF from a spinal tap, what are you looking for there?
Similar goal, ruling out other things, especially infection or malignancy involving the central nervous system. You check protein, glucose, account cytology, look for specific infections. And again, in classic Tolosa-Hunt, the CSF should be normal. If you find like significantly elevated protein or a high white cell count, that points away from Tolosa-Hunt and towards maybe a neoplastic process or some kind of meningitis.
Right. Now, one thing often mentioned with Tolosa-Hunt is the response to steroids.
Yeah.
How does that factor into diagnosis?
It's definitely a supportive piece of the puzzle. A really rapid resolution of the pain, usually within, say, 24 to 72 hours of starting glucocorticoids, is considered a key supportive feature.
The pain relief is quick.
Typically, yes. And then seeing the nerve problems, the ophthalmoplegia, improve over the next few weeks, maybe 2 to 8 weeks, along with improvement in the MRI findings, that further supports the diagnosis.
But I sense a but coming.
You're right. But a good response to steroids is not diagnostic on its own.
Why not?
Because other things, like lymphoma, like certain vasculitides, can also respond well to steroids, both symptomatically and on imaging.
Okay, so it's helpful if it happens, but doesn't seal the deal.
Exactly. You have to stay vigilant. If that prompt pain relief doesn't happen, or if symptoms come back after initial improvement, you absolutely need to dig deeper. Maybe repeat the CSF, maybe even consider a biopsy of the tissue if it's accessible to really rule out those mimics.
So putting it all together, the symptoms, the imaging, the labs, the steroid response, are there official criteria?
Yes. The International Headache Society, the IHS, has criteria. Basically, you need the unilateral headache. You
Mm-hmm.
need evidence of granulomatous inflammation, that specific type in the cavernous sinus or nearby structures, seen on MRI or confirmed by biopsy. You need the weakness, the paresis of those ipsilateral cranial nerves, third, four, or six.
Ipsilateral meaning same side as the headache.
Correct. And crucially, the headache has to come before or along with the nerve weakness within about 2 weeks and be on that same side. And the final point, probably the most important, the symptoms can't be better explained by some other diagnosis.
That last point seems key, given everything we've said about mimics. How good are these criteria?
They're pretty sensitive, meaning they're good at picking up most true cases of Tolosa-Hunt, maybe 95 to 100% sensitive. But the specificity is lower, maybe around 50%.
Meaning other conditions might fit the criteria too.
Potentially, yeah. Unless you really use any atypical features to actively exclude those other possibilities, biopsy is the gold standard for proving that granulomatous inflammation, but it's invasive and not usually done routinely, so diagnosis often rests on that careful exclusion process.
Which brings us squarely to the differential diagnosis. Ruling out those other possibilities sounds like a long list.
It really is. Anything that causes mass effect or inflammation in that cavernous sinus area is on the table. We can group them.
Okay.
First, you've got trauma, obviously. Then vascular causes aneurysms are a big one, carotid artery or others nearby. Also, carotid cavernous fistulas, thrombosis, even artery dissection. These are often emergencies.
Definitely need to rule those out fast.
Absolutely. Then you think about neoplasms tumors. Could be primary brain tumors like pituitary adenomas, meningiomas, or cancers that have spread there, metastasized from elsewhere like the nasopharynx or lymphoma, myeloma.
Right, tumors are a major concern.
And then there's inflammation and infection. This is a big category. Bacterial infections spreading from sinuses, fungal infections like mucormycosis, which can be devastating, especially in diabetics, viral like herpes zoster, syphilis, TB, and then other inflammatory conditions that aren't classic infections like sarcoidosis, GPA vasculitis, orbital pseudotumor, even things like IgG4-related disease.
You mentioned orbital pseudotumor. How does that relate? Is it the same thing?
That's a good question. It's basically idiopathic inflammation in the orbit, the eye socket area. It often causes more obvious eye bulging, redness, swelling than typical Tolosa-Hunt, which is more focused deeper in the cavernous sinus. Some think they might be part of a spectrum of the same inflammatory process in different locations. Both tend to respond to steroids.
Interesting. So location is the main difference there.
Yeah.
Are there any other miscellaneous mimics?
Yeah, a few others to keep in mind are diabetic ophthalmoplegia, though, that usually affects just one single nerve. There's ophthalmoplegic migraine, now often called recurrent painful ophthalmoplegic neuropathy. And giant cell arteritis, especially in older folks, usually has other symptoms like scalp tenderness.
Wow. Okay, that is a lot of possibilities.
Yeah.
You said clinical features alone often aren't enough to sort it out.
That's the challenge. Onset can be sudden or gradual in Tolosa-Hunt, but also in aneurysms or tumors. If you see clear signs of orbital congestion, the bulging eye, redness, swelling that points more towards orbital disease, or maybe cavernous sinus thrombosis, fever obviously screams infection.
Right.
This is where recognizing features that are atypical for Tolosa-Hunt becomes really important for pushing you to consider these alternatives more strongly. The overlap, especially with other inflammatory conditions that might also respond to steroids, can really muddy the waters.
Let's talk about those unusual features then. What things might show up in a patient that should make a doctor pause and think, maybe this isn't Tolosa-Hunt?
Okay, good question. One thing is the timing of pain and weakness. If the ophthalmoplegia, the weakness, clearly starts before the pain, that's atypical. Usually pain comes first or simultaneously.
Okay, weakness before pain is a flag. What else?
Bilateral symptoms right from the get-go. As we said, Tolosa-Hunt is typically unilateral at onset. If both sides are affected initially, you should definitely think more strongly about other systemic inflammatory conditions or infiltrative processes.
Makes sense.
Also, the location of the pain. If it's more of a diffuse hemicranial headache, like one whole side of the head, rather than that focused retroorbital pain, that's less typical too.
What about the steroid response? We know it's usually rapid, but what if it's not?
That's a big one. If you don't see that significant pain relief within, say, 72 hours, maybe up to a week, despite adequate steroid doses, that's a major reason to reconsider the diagnosis. Or if the response is very slow or incomplete, younger patients sometimes respond even faster, so a lack of rapid response is quite suspicious.
And you mentioned recurrences are common. Anything about the way it comes back that might be atypical?
Yeah, relapses happen in maybe 25 to 50% of people. But if a relapse brings new or different symptoms that weren't there the first time around, maybe different nerves involved or other neurological signs that warrants a full reevaluation to look for something else, like an evolving inflammatory or even neoplastic process, relapses can happen on the same side, the other side, or both, but it's the nature of the relapse symptoms that matters.
Okay. How about the MRI findings? Are there MRI patterns that just don't fit Tolosa-Hunt well?
Yes. If the inflammation seen on MRI is mainly outside the cavernous sinus or superior orbital fissure area and doesn't seem to be just spreading directly from there, that's atypical. Tolosa-Hunt inflammation is typically quite localized to that specific anatomical region. Widespread or multifocal inflammation suggests other diagnoses.
And the lab test blood and CSF was that they're usually normal, so significant abnormalities are a red flag.
Absolutely. Any major abnormalities in blood work, like very high inflammatory markers, specific autoantibodies, or significant findings in the CSF, like high cell counts or protein, should strongly point towards an alternative diagnosis: systemic inflammation, infection, malignancy. Even mild abnormalities need careful thought.
And lastly, what about the treatment course itself? Does needing ongoing or stronger treatment raise suspicion?
It can, yes. While some Tolosa-Hunt patients do need longer-term treatment or relapse management, if someone fails to stay well after tapering steroids or requires continuous high doses or potent immunosuppressants just to control symptoms, you really have to question if the initial diagnosis was correct or if it's perhaps an atypical presentation of another chronic inflammatory disorder.
Okay, that gives us a good handle on the warning signs. Let's flip it one last time. When can you feel reasonably confident that it's not Tolosa-Hunt, that you can likely rule it out?
Well, the most straightforward situation is when you definitively find something else.
I like.
Like the MRI clearly shows a tumor or an aneurysm, or your blood tests or CSF cultures come back positive for specific infection, or you find strong serological evidence for another inflammatory disease like GPA, and the clinical picture fits that better. A clear alternative diagnosis trumps Tolosa-Hunt.
Makes sense. What about the presentation itself, if it just doesn't look like the classic picture?
Right. If you don't have that typical retroorbital pain preceding or accompanying the ophthalmoplegia, if it starts bilaterally,
Mm-hmm.
if the pain isn't really focused behind the eye, especially if there are other neurological signs developing that don't fit with problems in cranial nerves third, 4E1, or Phi within the cavernous sinus area, then Tolosa-Hunt becomes much less likely.
And the steroid trial we talked about, if that fails.
Yeah, failure to show significant clinical improvement, especially that rapid pain relief within about a week of starting adequate steroid doses, is a very strong argument against Tolosa-Hunt. It's such a characteristic feature, its absence is telling.
And what if the neurological problems just keep getting worse or spread beyond that initial eye nerve involvement?
That's another key point. Tolosa-Hunt usually causes episodic dysfunction of those specific nerves. If you see relentless progression or deficits appearing in completely different neurological systems, that strongly suggests an active, progressive underlying disease process that isn't Tolosa-Hunt.
This has been super helpful for getting a practical grasp on Tolosa-Hunt. So just to quickly summarize the really key points.
Yeah, I mean, you suspect it based on that painful ophthalmoplegia, usually unilateral. Diagnosis hinges on MRI plus excluding everything else with labs and CSF. That rapid steroid response is supportive, but remember, it's not proof.
Right.
And you've got to be really watchful for any atypical features in the symptoms, the imaging, the response, because those are your cues to broaden the search for mimics.
And it really drives home that even though Tolosa-Hunt itself might be considered relatively benign compared to some mimics, you absolutely have to do that careful differentiation because there's no single definitive test.
Exactly. Close follow-up, clinically and sometimes radiologically, is often needed. Misdiagnosis can happen even when you're being careful.
So that leads to a final thought for you, our listener. Considering this diagnostic challenge, the overlap with other conditions, the non-specific findings, what do you think is the single biggest hurdle in confidently diagnosing Tolosa-Hunt syndrome in actual clinical practice day to day?